Yeah, thank you for that generous introduction. And with all the comments that have been made about the keynote speech, I feel a bit under some pressure. But I'll see if I'll live up to it. I will be in breach of protocols if I say I'm going to stand on existing protocols. I just must recognize some people by name, and I hope you'll indulge me. I think the national president of the PSN has left. Mazi Samo Habonwa, possibly the next president of the Federal Republic of Nigeria. I want to also recognize our evergreen, Prince Julius Adelusi Adeluyi, has always been a role model and an icon of the profession, and we appreciate you, sir. He's always there for us. I understand Dr. Dere Awoshika will be coming back. After listening to our address as the chairman, the temptation is to say I agree with her in total and go back to my seat because it covers quite a bit of what I'm going to talk about. I must mention the chairman of the Board of Fellows and my teacher, Professor Mrs. Mbang Femi Oyewa. She's also evergreen. She taught me about 35, 36 years ago. And would you believe that, somebody just mentioned her age. Will you believe she's over 40 years old? Okay. Pharmacists Iyolagbolagade are hosts in Lagos. Of course, the chairman of Nigerian Association of Industrial Pharmacy, IG Anyoku. A lot has been said about your energy, about your commitment to the cause of the association, and I'm a personal beneficiary of your commitment to elevating every member of the association. But we can't say everything here, IG, because we've been sworn to an oath of secrecy. Okay. I must mention particularly my co-former chairman of the National Association of Industrial Pharmacists, Pastor Adepopuola. He handed over to me an empty office space and one staff in 2003. But that's just a statement. It's not a criticism because it just speaks to the very, very humble beginnings of NAIP. And to think that 15 years later, we're here where we are today, I think we should be proud, all of us, for the little successes we have made. And of course, Dr. Lolu Ojo, he held the room during his own tenure as well. And all fellows of FIP, there's none here, I'm sorry. All fellows of PSN present, leaders of the profession. I must mention the publisher of Pharma News, Sir Ifeanyi Atoyi, and Professor Cyril Osifo, my senior at the University of Ife. And of course, I stand on other protocols. Thank you very much. So I go to my keynote address. Technological revolution, adaptation in industrial pharmacy practice. This topic, if it was chosen 20 years ago, will have been relevant. If it is chosen 20 years from now, it will still be relevant. And I'll tell you why. Because it appears that the revolution that we are witnessing in the healthcare space is unending. While we're yet to see the end of the revolution triggered by information technology, we're already thrown into the vortex of another, a revolution that is being powered by biotechnology. To give a sense of the scale of the change that can be wrought by a revolution, I want to use an example that we are living in and we are very, very familiar with, a pandemic. And I'm trying to quote, of course, I'm quoting directly from the Financial Times of the 26th of February, 2021. And it is an article written by one of my favorite authors, Yuval Harari, and he says it, succinctly. He said in 1918, when the influenza pandemic struck, the best scientists in the world could not identify the virus. Many countermeasures adopted were useless, and attempts to develop an effective vaccine proved futile. Now it is very different with COVID-19. The first alarm bell about a potential new epidemic started sounding at the end of December 2019. By January 10th, just 3 weeks later, scientists had not only isolated the responsible virus, but also sequenced its genome and published the information online just in 3 weeks. So in 3 weeks, the entire world already knew all the bases, all the makeup of the genes of this virus. So it became clear immediately which measures could slow and stop the chain of infections, and within less than a year, several effective vaccines were in mass production. And he concluded by saying, in the war between humans and pathogens, never have humans been so powerful. Well, suffice to add that the 1918 Spanish flu killed between 17 and 100 million people. That in itself is a problem because we're not even sure of how many people died. But 17 million in any language is a huge number. And to think it could be 100 million, that is sobering indeed. And just like COVID-19, it also had a fatality rate of just 2%. So central to the topic of this conference theme is the word revolution. And the Webster Dictionary, in one of its definitions, describes revolution as a sudden, radical, or complete change. However, to put things in context, this keynote address will describe who the industrial pharmacist is, how previous revolutions have affected the practice of industrial pharmacy, how the industrial pharmacist has survived past revolutions, and prescriptions for coping with future revolutions. Well, starting with the definitions. The industrial pharmacy, we could say, straightforward definition is, and I'm picking from the definition of the International Federation of Pharmacists, FIP, are pharmacists who work in the pharmaceutical industry or have interest in activities of the industry. This also will co-opt people in academia or consultants who are directly not working in industry but actively research or support the industry with consultancy services. And the scope of functions will include product development, formulation development, drug production, quality assurance, regulatory affairs, logistics, supply chain management, and marketing. Okay? So we go into a bit of history. Which are the revolutions that we've witnessed in the past, and how has the industrial pharmacist coped? Okay? The calling that is the precursor of the modern-day pharmacist combined the role of the apothecary who prepared materia medica in pestle and mortar or just mixed something in a solution and offered them to individual patients. He combined this role with the function of the physician in diagnosing and prescribing treatment. So in the very early ages, there was no separation between who a pharmacist was and who the physician was. Okay, but by the Middle Ages, we're talking 14th, 15th century, there was a separation of the function of preparing therapies from the specialty of the physician in diagnosing and prescribing treatments. The apothecary was at this stage was still making preparations that were both extemporaneous and individualized. You know, every person who walks into the apothecary's shop got his prescription. 7 days, 1 month, but nothing longer than that, and it was individualized, not industrial. Industrial large-scale production of medicines did not start until the mid-19th century. We're talking about the 1850s now. So in the context, in the scheme of things, our profession is very, very young indeed. Okay? And the influence for industrial production of medicine came from the scientific, I'm using this word for the first time, scientific and industrial revolution that started in the 17th century. Okay, so the first revolution that really led to the birth of our profession was the industrial revolution of the 17th century. And our profession did not really take benefit of it until about 100 years later. So I hope we're keeping these timelines in view. Okay? So by the middle of the 19th century, the companies that eventually mutated to Pfizer, Merck, and GSK, as we know them today, were the ones that were forebears of the industry. At this point in the history of the industrial pharmacist, he was simply an industrial chemist, manufacturing medicines in bulk, using processes not too different from production of other bulk chemicals. Here we're saying that the industrial pharmacist of those days was no different from those manufacturing cement, fertilizers, paint, and all the rest of them. We just manufacture things in bulk, break them into individual doses, and distributed them. No finees, you know, no rigors about it at all. Okay. However, the first half of the 20th century, now we're in 1910 to 1950, witnessed 2 world wars, and more importantly, the National Health Service in the UK and similar social programs in the rest of Europe. This is the second revolution that triggered a change in the practice of industrial pharmacies. And what is the implication of this? This seemingly on a related event attracted a lot of funding into the pharmaceutical industry. Governments had to support soldiers that were in the war front with medications and different kinds of treatment because of horrendous injuries and the rest of them. And of course, because the NHS and the other similar social health programs that were introduced in Europe had to cover practically the entire population, all of a sudden, the market for industrially produced pharmaceutical products exploded. So this, combined with improved knowledge of chemistry and biology, triggered massive activity in research between 1920 and 1980 and led to what was then called the golden age of the pharmaceutical industry. Insulin is 100 years old this year. Penicillins, paracetamol, ibuprofen, diazepam, the contraceptive pill, monoamine oxidase inhibitor class of antidepressants, cimetidine, the first blockbuster drug. Blockbuster means the first drug to clock $100 billion in sales. All of them were discovered during this golden age, between 1920 and 1980. But unfortunately, the second revolution, this in industrial pharmacy practice, and please listen to this. Unfortunately, this period also witnessed some of the darkest chapters in the history of the pharmaceutical industry. In 1937, over 100 people in the United States died of diethylene glycol poisoning following the use of sulfanilamide elixir. Does that sound familiar? My Peking. Yeah, we're still living that kind of era, you know, about 80 years later. Then there was also the thalidomide disaster between 1958 and 1963, which led to over 10,000 children being born with deformities. These 2 events attracted a lot of scrutiny to the industry and led to more stringent oversight. Then the distinction between production of medicine and bulk chemicals became inevitable. So the pharmacist can't just be your industrial chemist anymore. He has to do more. And what was the mandate of the public? So the pharmacist now has to combine his role as a production pharmacist with the task of what is now called the quality superintendent. And in practically all jurisdictions today, it is a role that the pharmacist in industry has not shared with any other professional. And I took a trip around the world to see how they manage the industrial production of medicines and the role they give to pharmacists in this process. And what I found is that in most countries, the pharmacist is legislated into the statutes. In Nigeria, he is called either the drug analyst or superintendent pharmacist. We're very familiar with that. In France, he is called the qualified person. The qualified person can only be a pharmacist and is the only person that can release a drug into the market. In South Africa, very similar to us, is the only person legally recognized to also release medicines to the market and submit dossiers for registration, whether for local products or imported products. In Brazil, he is called the technical responsible pharmacist, and his role is similar to that of the qualified person in France. In Cuba, they didn't name a pharmacist, but what they said is for you to be qualified, they call it authorized person. That's what they call them in Cuba. For you to be an authorized person, you must have a bundle of skills that only the pharmacist can have. Okay? So yes, it's not legislated and said that only a pharmacist can be a qualified person, but the truth is that by the time you read through the statute, only the pharmacist can be the qualified person. So even in other parts of the world where the pharmacist is not written into the statute, the breadth of his knowledge and the skills are such that industry is more comfortable employing the pharmacist to oversight drug quality and safe use. So this established the role of the pharmacist in industry as we know it today. And I've tried to paint a picture of events in history that has led the world to accept that, look, there is no other person who can do this job in industry except the pharmacist. Okay? So now, let's look at technological advances that are also influencing the industry. The ones I've mentioned, social, not strictly speaking technological, social, possibly financial as well, but not technological. Now, let's go into technology. The first area of technology is biotechnology. And while the pharmaceutical industry was enjoying its golden age between 1920 and 1980, another revolution was brewing in information technology. Sorry, I meant information technology here. Moore's law was having a full effect, with the speed of computers doubling and the cost of storage halving every year. Application of this in the pharmaceutical industry sped up the ability to screen drug candidates, shortened time to market, and enabled more targeted therapies. There were huge advances in the handling of small molecules. However, the real revolution was triggered when the advances in computing was applied to genetics and proteomics. This marriage launched the age of immunotherapy, and one immediate impact was in the complete mapping of the human genome. A project that initially was thought to be too formidable to be accomplished in a lifetime was concluded within 20 years at the end of the last century. I think by 1999, year 2000, the human genome was fully sequenced and mapped. The entire 3 billion letters that are in the human chromosomes were not only identified, but also mapped. Diseases with genetic bases are now better understood, and therapies can be better targeted. This revolution has upturned the pharmaceutical industry as we know it. It hasn't hit us fully in Nigeria yet, but it is coming, okay? In the year 2000, the top 10 selling drugs in the world were all small molecules. However, 19 years later, in 2019, 8 out of the top 10 selling pharmaceutical products in the world are big molecules derived from biotechnology. Also, as an indicator of the future direction of the industry, the category of new drug products granted approval for marketing by FDA in the year 2020 showed that large molecules constitute a whopping 25%. Ladies and gentlemen, the future is here, and hopefully we have not been caught flat-footed. Now, this is not an indictment of Professor Yewo, but when I graduated from pharmacy school over 30 years ago, I had audited several courses in chemistry. I was ready at graduation as an expert on the characterization, synthesis, and general handling of small molecules. I could control them for quality, handle them in the industrial processes, and generally able to predict their behavior in vivo and in vitro. I was your quintessential chemist and was ready for the pharmaceutical industry as it then was. Today's industrial pharmacists will be challenged to provide expertise on proteins and large molecules as agents of therapy. It will be expected to provide expertise on their structure, predict their behavior, control them for quality, and be involved in their industrial production. Where there has been a bit of enhancement in the undergraduate curriculum of most pharmacy schools to increase content of biotechnology, a lot still needs to be done to prepare the pharmacy graduates of today to confidently provide leadership in industrial production and quality control of biologics. A conversation between industry and academia is therefore imperative. Okay, so the second revolution is in information technology. And information and communication technology is still evolving. And the extent of its influence on every facet of our life is still at the level of conjecture. Now listen to these statistics. In the next 24 hours, 600 million tweets will have been sent, and there will have been 5 billion Google searches. WhatsApp will have processed 100 billion messages, 1.6 billion photos, and 15 billion minutes of voice and video calls. Add to this data generated by over 2.5 billion Facebook users and 5.3 billion unique mobile phone users, tens of millions of wearable devices, and medical and prescription data being uploaded onto the cloud from different hospitals and community pharmacies. Cloud computing is providing the infrastructure to store all this data, and big data is developing the ability to analyze them. Now, just imagine for a moment that the technology is there to be able to analyze every tweet, every text message, every WhatsApp chat, and it's there anyway in big data. And Google, I think about 10 years ago, really trialed an application where they were tracking words related to flu, like cold, like antihistamine, like flu, and things like that on all their Google searches and other applications. And with that, they were able to predict the onset of the flu season very, very accurately. So now, as an industrial pharmacist, if such an application becomes mainstream, do you know the implication for you? If you are a marketing manager, you know when to launch your campaign, your advertising campaign. If you're a procurement manager, you know when to start getting ready for a production campaign. If you're a production manager, you know where to slot flu medications into your production plan. So these are the kind of tools, the kind of strength that comes with having a handle on information technology. So like I was saying, this will provide capacity to predict epidemics and evaluate safety and efficacy of medicine on a global population. All these have implications for pharmacovigilance, clinical trials, inventory management, production, and marketing. And you can imagine how information technology has been deployed to track the experience of the populace as the vaccines for COVID-19 was rolled out globally, such that 86 cases of clotting disorders was noticed in 25 million administered doses in Europe. The clinical trials of pharmacovigilance of 20 years ago wouldn't have been able to do this. Clinical trials, if you had at the most 20,000 patients, everyone is fine. But this is showing that you're having clotting disorders in 300,000 cases. It will have been missed in clinical trials. And pharmacovigilance that was not based on information technology, of course, probably will have also missed this as well. Dr. Oshika mentioned artificial intelligence. It's been deployed also in the pharmaceutical industry, but basically in research and devoted to designing machines and softwares that learn and solve problems. It is being deployed in development of medicines with the optimal structure and shape for enhanced efficacy and reduced side effects. She also mentioned that 3D printed drugs is already approved by the FDA, and quite rightly, as far back as 2015. So a few more formulations of 3D printed drugs have been approved. So I think the community pharmacists and hospital pharmacists of the future will have among their staple of equipment a 3D printer and cartridges containing different chemicals with which they will produce medicines a la carte. But then it begs the question, what will be the role of the industrial pharmacist in this? Because at the end of the day, I think we have the overarching responsibility to ensure quality. Okay. Luckily for NAIP, a Nigerian, Dr. Kabir Umar of Bayero University, Kano, just graduated with a PhD from an European university studying the use of 3D printing in the manufacture of drugs. It will be a particularly useful resource for us. Still talking about information technology, logistics. I think the billionaires in the world are in a race to know who will get to space first. So it's looking like space is going to become routine, and it challenges us that supposing they have to take medicine to space, will it work? So we need to start thinking about that. But beyond that also, Zipline is a company, an American company, and it's perfecting deliveries of health consumables with drones. Pharmacists must start thinking about stability of formulations in the weightless environment of space, and exploit drones in drug deliveries to difficult-to-reach areas in times of wars, epidemics, and natural disasters. Drones are being considered for deployment of COVID-19 vaccines. The world will look to us to guarantee the stability of vaccines that must be delivered by drones while maintaining a cold chain at a minus 25 degrees Celsius. All this presents tremendous opportunities and challenges. Rwanda, a country in Africa, is already studying the possibility this presents. Advances in logistics are also being exploited to drive efficiency in pharmacy practice. I mentioned Zipline earlier. This American company, which started by experimenting with drone delivery of medicines, has reached agreements with the Kaduna state government to start the service in Nigeria. In 2018, it served a population of 10 million people and 1,000 hospitals with 2,000 drone deliveries per day in Tanzania. This is a model that will become popular in the future. So as pharmacists, industrial pharmacists, if your remit is supply chain, you better start paying attention to drone deliveries. Now, another area that is becoming quite interesting is in combination products. Our engineer friends are breaking bounds and going beyond limits to design products that that our training and our regulatory system never foresaw. So basically, what we are familiar with is a combination product that involves a medical device and or a drug or biologic, combining either a drug with biologic or combining a drug, biologic, and a medical device is what we describe as combination product in this context. We are familiar as pharmacists with prefilled insulin syringes. That's the basic one that you can say, okay, yes, I'm familiar with that. So I'm just trying to use that as an example. Or metered dose inhalers, they are also combination products. But start getting complicated when, for instance, you have catheters that have antimicrobial coatings, or you have stents that have anti-clotting agents, okay? And or bone cement with antimicrobial agents, or bioartificial pancreas that supplies insulin as needed, all embedded in the person, okay? Yes, sometimes these products are developed by engineers, but they just don't want to go beyond designing the product. They can't engage regulatory authorities, they can't engage the healthcare community, and you can't blame them. They have no training, absolutely, in biology, and they devolve to us. But then we are not engaged in that space, okay? So you can imagine an engineer taking a bone cement with antibiotic to NAFDAC, and they ask him, okay, have you done the bioequivalence studies? And we'll start asking, what do you mean by equivalence? So we need to start engaging that space, and because a lot of interesting products are coming. And Dr. Oshika alluded to that, Internet of Things, tablets that are communicating as they are passing through your system with the cloud somewhere. And, so very interesting thing coming up. So it is obvious that biotechnology and information technology will shape developments in industrial pharmacy practice for the foreseeable future. Combination products will become more important. And when I graduated 35 years ago, I did not audit any course in information technology. So I'm certainly not suited for the pharmaceutical industry of today. So, ladies and gentlemen, having described what the situation is today and what is likely going to be in the immediate future, what are my prescriptions for adaptation in industrial pharmacy practice? Number one is our education and curriculum. Adaptation to the requirement of practice today will start with continuing education. The Pharmacists Council of Nigeria must be specially commended for developing a sophisticated and IT-enabled platform for continuing professional education, including modules in biotechnology, proteomics, combination products, and information technology should be easy for industrial pharmacists already in practice. Furthermore, undergraduate curriculum should be richer in biotechnology and information technology. And maybe it is time for industrial pharmacists to start a discussion on a different track for training industrial pharmacists, as we have for community pharmacists and hospital pharmacists who graduate now with a PharmD. PharmD is, strictly speaking, a patient-facing, is a degree for patient-facing pharmacists. They haven't factored industrial pharmacists into it. And again, I took a trip around the world to see what best practices are. In Switzerland, a degree in pharmacy wouldn't get you into the industry. You will only work in hospital or community. For you to work in industry, your degree has to be in what they call pharmaceutical science, okay? In Germany, after your degree, usually they graduate with a master's it's very unlikely you will easily get into industry unless you get a PhD in an industry-related area. So these are the kind of examples we have from other parts of the world. So the second prescription I have is research. I know NAIP is not extraordinarily rich. Academic pharmacists won't agree with that. But I'm aware that some money is being spent on research. I want to encourage this. So however difficult our finances are, let us continue to devote money to research that will promote the relevance of industrial pharmacies in the scheme of things. As a member of organization of the FIP, you can also attract collaboration and sponsorship for research if it aligns with some of the strategic pillars of the FIP. In the first half of my tenure as president of the industrial pharmacy section of FIP, we have chosen as our special project an interrogation of the role of pharmacists in industry. People might find this curious, but the industry is in a state of flux, and sometimes we ask ourselves, what is it in industry that we should call our own? Because in different parts of the world, you find encroachment from other professionals. So we want to interrogate that question. What should we be saying to a CEO, to an HR director, to even business owners that, look, these roles should be specifically meant for pharmacists, because we have different things in different parts of the world. It's particularly bad in the US, where you practically don't have pharmacists in industry. And the reason is because there is no pool from which to draw industrial pharmacists from. All the pharmacists that graduate go straight to community. Why? Because of the money. It's a lot of money. And industry can compete. So basically, from the beginning, you don't have people in training who can step up into industrial pharmacy roles. So that's what we're going to be working on. The third thing I will encourage is collaboration. This may sound trite, but one of our greatest strengths as industrial pharmacists is our exposure very early in our careers to other professionals. In our manufacturing plants and in management committees, we work with engineers, accountants, lawyers, human resource experts, etc. Industrial manufacture of biologics and medicines is getting very complex, and it has attracted expertise from different fields, including politics, law, investment banking, and regulatory affairs. You may wonder what has politics got to do with it, but for God's sake, there is no way COVID-19 vaccine will have happened without politicians. In 12 months, it's not possible. It is not possible. And the lawyers who negotiated those contracts, God, now you have pharmaceutical companies pushing drugs into the market and absolutely not bearing any liability. No liability at all for any adverse outcome. Can you imagine that? First time in the world. So, but for us as pharmacists in our little corners, if you put that before a pharmacist, oh, no. We have to bear responsibility because it's our product. But lawyers think differently. So, the summary is that let us remain humble, let us be willing to engage, and let us be willing to talk to other professionals going forward. And I said I will illustrate this with the current pandemic. The AstraZeneca vaccine, for instance, was done by a team at Oxford University in the UK. Development, which in this context means formulation studies, clinical trials, and quality documentation, was done by AstraZeneca, a British-Swedish company. Basic research and development and industrial production was financed by the British government largely, because when you say, I'm going to buy 1 billion doses over the next 3 years, you are practically financing production. Then industrial production is being done in facilities in Belgium, in India, and Australia. And added to this, there's an IT infrastructure at the back end that will collate patient experiences in real time and for up to several billions of patient interactions or more. Our practice requires that we remain humble and exploit the knowledge of other professionals to remain relevant. I can't stress this enough. Then, this I think is the most important of all my prescriptions. And please listen to this. The contribution of the pharmaceutical industry to Nigeria's GDP is lower than 0.25%. Well, I've been corrected. It's not up to, it's much lower than 0.25%. Believe it or not, in Republic of Ireland, it's up to 20%. In India, it is 2%, okay? Until we increase the size of the pharmaceutical sector in Nigeria, politicians and the investment community will not take us seriously. I just did a quick check. The entire size of the pharmaceutical industry in Nigeria is not up to the turnover of Dangote Cement. It's not up to the turnover of MTN. So you can see that we still have a long way to go. So what do we need to take us there? It's something I've called the revolution of the mind. For the CEOs and the directors of marketing among us, we must break away from the shackles that make us define Nigeria as our total markets. We have the prospect of quadrupling our markets by simply defining it as Africa. We have the advantage of closeness, culture, race, geopolitics, in our favor with respect to our African brothers. We are by far the largest and most sophisticated pharmaceutical powerhouse in sub-Saharan Africa. This should count for something. So basically, if we think that competition is very, very toxic and very serious in Nigeria, we have only 140 or maybe 160 pharmaceutical production company, okay? India has 3,000. China has 5,000, okay? And when I left school, there were only 4 pharmacy schools. I think now we have up to 20, and they're churning out pharmacies by the numbers. So the competition is going to get keener, okay? And the only way, and we're beginning to see evidence. In fact, the evidence has always been there of very toxic competition, Receivables of, you look at the balance sheets of pharmaceutical companies, you see receivable days of 6 months, 9 months. 2 years. So I'm starting off a riot, so let's go on to something else. So those are evidence of very toxic competition. I mean, if somebody is not paying you, for God's sake, stop supplying him. They won't do that with people in other industries. So the way to really take them on is to broaden our markets. And like I said, just basically defining your market as Africa will change perspective a bit, okay? And the thing that is in our favor is that the 54 countries in Africa are turning Africa into just one regulatory agency through the African Medicine Agency. And of course, the Africa Free Trade Area is also trying to turn Africa into a single market. All this will come together to make it easy for us to play in, to play in Africa and turn it to a single market for all of us. We also have 3 functioning WHO pre-qualified facilities in Nigeria, I think. I may be wrong. A WHO pre-qualification is as good as FDA or EMA certification. So why are companies with such certifications not including US and Europe as potential markets? If they do that, a potential market of $1.5 billion in Nigeria suddenly explodes to a potential market of $1 trillion. And the rules that guide international trade is very different from what guides Nigeria. Once you get your order and you ship, you are sure of your money. You don't have to beg anybody for it. You don't have to send a delegation to Minister of Health or whoever. So number 5, we need to start identifying trends and exploiting them very, very quickly. Okay? It appears mRNA, messenger RNA, will be the platform for producing biologics in the future. Can NAIP sponsor a study to identify how Nigeria can lock itself into the value chain of mRNA biologics and become a global player? I can't overemphasize this enough. mRNA is going to be very, very important. But we don't have to be in every part of the value chain. In biologics production, there's a division between upstream and downstream. You can just pick one of them, that we think, yes, we can easily play in and start playing there and become a global leader in that sphere. In Africa, South Africa has beaten us to it. I think a company, Aspen Pharma, is developing capabilities in becoming a leader in production of mRNA biologics downstream, not even upstream. So we should look at that. So lastly, I want to mention that another thing we can exploit is FIP. And I'm saying I will not end my address without sharing with you the extraordinary rich resource that FIP represents. It is your link to a network of 2 million pharmacists the world over, and 200,000 among them who work in industry. The network can give you insight into trends in the industry and the direction the industry is headed. It is a vital resource for problem solving. So whatever challenges you may be facing in your factory or laboratory, there is someone in one corner of the world who has probably successfully confronted such a challenge. The annual FIP conference gives you access to over 70 sessions discussing different aspects of pharmacy and opportunity to meet one-on-one with leading lights in the profession. The poster session and short oral presentations give you snippets of advances people are making in science and practice in different corners of the world. Participating in an annual conference indeed makes you immensely proud to be a pharmacist. I recommend that you put it in your bucket list for immediate future and be part of one. Distinguished colleagues, ladies and gentlemen, I thank you for your attention and wish you all a phenomenally successful conference. Thank you very much.
Thank you. You can continue, please. Thank you. Wow. Chop knuckle from distinguished chairman. And so thank you. All right. You may sit down now. That was mind-blowing. You had the 1 minute advert of it, and then you have the full session.